Thank you to IG Catalyst to sponsor that session. Indeed, Monif is coming from the Ministry of Health in Saudi Arabia. He has had his fingers in imaging for the past 15 years, 20 years. We stopped counting. And we have in this session also some other speakers. We have Rick Busbridge, who is going to speak this early afternoon on some of the multi-country working group recommendations. He's working for NICTIS, and he's contributing and preparing the national image sharing project for Holland in the forming stage, not yet gelled, but good progress. We will have this afternoon also Genaël speaking from the Agence e-Santé from France. And Genaël, who is working as we speak. He's one of the two lead of the national imaging project, which is about to roll out. So it's all done, just to be implemented. And she'll tell us how she can commit to have it implemented in less than 2 years. And she has a few million euro in her pocket to make that happen. So you'll see she got several tricks to get the ball moving fast. And Rick is going to come back this second part after the break to really speak about the EHDS and the European use case. Imaging is a fairly easy use case. Everybody in EHDS is going to tell you, oh, it's hard. We're not sure when we'll be able to do it. It's going to take a lot of time. Wrong. It has been working for 20 years and working quite well at large scale. So we have a ton of experience, and we can roll that use case rapidly as long as people pay a little bit of attention in the EHDS. And Rick is going to explain the good progress that has been made, and we expect even faster progress to be made in the next few months on that. So that's the menu. I need to introduce myself. My name is Charles Parisot. I'm representing here IG Catalyst, and when I contribute to the French national project with Genaël, I'm a contractor from IG Catalyst. I'm a self-contractor, if you want. I'm retired from a corporate job. I've been working with GE Healthcare on interoperability, national and international, IGHL7 and all of those things for about 29 years or so. So, you know, the field is not new. And I was also among the folks that helped starting the EPSOS project. For those who have heard it mentioned, this is the ancestor of EHDS that was launched in the 2005, 6, 7 time frame. And at that time, we had everything to invent. So EHDS appears, in a sense, simpler, but has many pitfalls because the cross-border has been working so well that the politicians have been walking ahead of their capability of what can be managed on the governance standpoint. So we have very few technical problems, but we'll have massive organizational and governance a problem. So we want today to speak mostly of the technical part, use case part, clinical part. We're going to speak hardly any or very little about the governance of EF's project, except when Monif is going to speak to the Saudi project, or Genaël speak to the French project, and Rick will also give us some sense as to what's being put in place in EHDS. So that's more for this afternoon. So, next slide. So am I supposed to do something to move the slides? I click, nothing happens. Oh, that's a revolutionary tool. You have to push on the cursor. Wow. Okay, I didn't know those things were still useful. Good. So this is our program for the first part until the break. So the first slot is we're going to be focusing on the use case. It's impossible to work on something and speak about interoperability if we have not shaped what is the problem we're trying to solve. So what we are doing for this 30-minute is to speak about the imaging use case that is defined by a e-health network guideline at the European level, and that was work that was done in 2023. And the reason why we are using this is because this EHDN guideline has invented nothing. It simply states what everybody does. So why taking another document? It makes the European folks happy. They think they've invented something when they've actually put on paper what everybody understands and is trying to do when they speak of sharing imaging information. So we're going to use that as a starting point, but feel free to criticize, because this use case voluntarily ignores some use cases that may need to be addressed eventually. Are they priority or not? Why have they not been made priority? You know that the art of use case is decided on the use case you will not implement. It's actually the most revolutionary decision you make in an e-health project. So that's going to be our first theme. And then we'll move to the multi-country working group. We'll have a chance to explain a little bit more what that group is, but that group is also has decided a year and a half ago to also start and is using the imaging information exchange use case from the EHN guideline as their basis. So the EHN guideline on imaging, you see that's imaging studies and report. Good point at the European level. Imaging studies and report. Why? Because the average project says, oh, images, they're big, they're complex. I'm just going to do the report. I'll do the imaging study afterwards. Sounds like a good idea. Very bad idea. It's actually a losing idea. Let me explain why. Because when clinicians are working on imaging report or images, they go back and forth between the images and the report. For them, it's two sides of the same coin. So if you think of the use case to do the report alone, guess what? When you add the images, you say, oops, forgot this, oops, forgot that. You have to redo the sharing of the report. I'm sure Guénaël is not proud about it, but that's exactly what the French program did. 3 years ago, they deployed the report, imaging report alone, and say, then we're going to do the imaging. And when time came to define the imaging use case to make the two work together, there was 2 or 3 hoops to be corrected on the imaging report. Now, people don't believe it. Your program is going to make the same mistake. You'll have to fight very hard to tell them, stop. You have to design both together. You may deploy one ahead of the other, but it's a single design. So that's what this guideline is covering. And in what it is covering, there are things that are covered very well, and it is the use case. The use case description, we're going to spend some time on it, is actually pretty well done. Why? Because It uses the methodology that was introduced 10 years ago by Aichi in European project on how to define a use case, short but clear. And you'll see there is an interesting table that is not earth-shattering, but that people forget to use. And when you use that table, you typically cover your use case in such a way that everybody understands. It's non-technical language, and it's very extensive. Not necessarily completely extensive, but it does a fairly good job. The EHN guideline has also a semantic consideration part that is, shaping things. Speaking of data that has to be in the report, in the imaging study, it speaks about it, but it doesn't define each piece of data. It doesn't tell you the data type. It doesn't tell you the cardinality, if it's mandatory, and if it's dependent on others, and if there are conditions. No, not at all. So it's not a semantic spec, okay? For those who use FHIR, it's not a structured data description. It is not. It is the first 5%, if you want. The 95% are not covered. Then there are some technical considerations that talk to transactions and stuff like that at a high level, at a very high level, but at a level which is useful. Because especially with imaging study, many people are lost. They say, wait a minute, images are big. There are thousands of images in a CT scan. How do I move all of those things? One by one, as packages, as series. Okay. So transacting in the world of images is raising a number of issues, and those main issues are actually covered by the EHN guideline. And then he talks about standard, and he says, I will need DICOM, yeah. I will need HL7, yeah. I will need SNOMED, yeah. I'm going to use it, not for this spec. We'll do that in a separate technical specification. So don't expect the EHN guideline to be something you can take and say, give to an implementer. I say, on these packs, could you implement the necessary interoperability to share imaging study? They're going to open the book and they're going to say, yeah, it tells me what I could do, but it doesn't tell me how to do it. So let's not overemphasize what that guideline is, but it is a phenomenal starting point. So we know that this is one of the 5 use cases of the European Electronic Health Record Exchange format. There are 5 use cases. And this guideline is actually covering multiple use cases, but has identified one as a use case 1 of priority 1. So guess what? The rest has not been looked at yet. But it's listed, it's of interest. It shows that some people were very conscious of not covering certain use cases initially. Let's open the infamous table that has been defined in the European interoperability framework more than 10 years, more like 15 years ago. And that was a proposal from Aichi, and that is now being used by many, if not most, European projects. You speak to the purpose of the use case in a few lines, in lines that even a politician would understand, that any clinician would understand, that the cleaning lady at a hospital would understand. Okay, so it better be simple and clear. Imaging studies and reports are made available in a cross-border context to a requesting health professional. So you see that use case 1 says, hey, I'm serving health professional. You'll see later that there are things to serve the patients. And it will say that when a previously performed study or a report is needed to make clinical decision, so that's what you can get. You can use that in case of emergency to access this information and provide continuity of care. It focuses on cross-border, but not only. This use case is also applicable intra-border. And you will see that the multi-country working group, made of 11 countries, is actually using this use case for intra-border information, imaging information exchange. Relevance. Pretty obvious things. I'm not going to go there. If you are in this room, it's because you know that accessing remotely and sharing imaging and imaging report and imaging study is useful to deliver better care, more efficient, avoid duplication of examination, compare results, and so forth. The domain in which the use case works, and here, IT Europe, the EHN, the European guideline, has taken the broadest possible scope. So basically it says, hey, any kind of imaging that DICOM address, which is all of the imaging needed in healthcare, there may be some few obscure exceptions, but all of those specialties can be covered and are potential to that use case. Now, most countries do not deploy this in all specialty domain initially. You focus on one or two, you make it happen, you spread, you add. Why? Because deploying interoperability requires clinicians to be on board. And if you take all of those specialty, that's a lot of people to convince and to engage and to educate. So it's not the technology which is the issue in most cases. It is actually the governance and the engagement of all of the players. The scale of the use case is cross-border, but it can be national and regional, and it's essentially between organizations. The context, I would say nothing earth-shattering here. When imaging report and imaging study are available, you can access them. The imaging study may contain maybe large number of them. Some patients have more than 100 imaging exam, and that's okay. There is this infamous word of metadata, which is high-level information that you can attach to an imaging study so that you can search them. Okay? So it's not all of the information in the imaging study, it's just a few attributes. We'll see those. The information that you are moving around, we see a new term being introduced, the imaging study manifest. So as we see, an imaging study is a funny animal. It's made of tens or hundreds of DICOM objects that are organized in series to form a study. So that's the imaging study. So you see, an imaging study is not one thing. It's already many things that have relationship between them. So what is being introduced is a concept of an imaging study manifest. It's a single document that basically summarizes what's in the imaging study. It has the list of the images. It has the identifier of the images. It identifies the subclass of those images. Some high-level information that basically when you read it, you say, okay, yeah, okay, I see what that study is all about. I know that the size. I know how to get it. Okay, fine. Very useful. Manifest, put the word passport, ID card, whatever you want to call it. But that is a mediating piece of information between the world of DICOM and the world of accessing information in large-scale deployment. The imaging report and the metadata on the imaging study and the report that is used for searching and retrieving the above imaging study manifest and imaging report. So the metadata, we say that's important. It will enable a number of things, and that's something Rick and I will further discuss later this afternoon. What are the participants to the use case? Oh, we say we are serving the health professional. Okay, both in the country where the patient has been initially imaged, but also in the country where the patient may be treated if it's a different country. And it has also the citizen and the patient. The citizen patient may not access its images in this guideline use case, but that's his images or her images. Therefore, he's a participant to the use case. The precondition, yeah, you need a little bit of bandwidth to access the images. You must have things organized fairly well with metadata. And there are some cases where you may need the relevant significant images. And there is a whole process step flow that is classical, where first you locate the patient in the remote country, you do a number of things, then on point 7, the health professional selects by filtering, ordering, grouping things. The country A provides the data that match the selection criteria set at 7, responding to a query. And the health professional 9 in the country B is presented with the requested imaging study. Oh, not the imaging study, manifest. Okay, so he sees what's available at a high level. He may or he may not get it. A manifest is a few kilobytes. The imaging study is a few megabytes, sometimes a gigabyte. That's point 9. And then it can provide its services and may decide or not to store that imaging study that he retrieved from a remote country or remote region or remote site on his local system. That's it. Any surprise? Anything you were expecting that is not there, or things you were not expecting which is there? Nope. Good. So we'll proceed on this. In the guideline, there are 4 other use cases. The patient accesses things. We'll see that in MCWG, we've taken both the professional and the patient. And many countries want the patient to have access to the images. Here it's the cross-border focus, which is mostly driven for professional need. Use case number 3, requesting second opinion. So we say here a number of workflows. Use case 4, you order an imaging study to be evaluated for a second opinion in another country, another place, consultation for rare disease. Use case 5, where you now have obtained a prior study, perform a new study in one country, and you give back the imaging information to the country of origin to the patient. And we see that all of those are priority 2 or priority 3, and therefore we will never speak about them again in this session. But next year there may be the primary topic to be discussed. So the scope of the guideline, we'll move a little bit faster now. Nothing earth-shattering here. Yes, we improve care, we avoid retaking existing exams. We assume the DICOM object requested are available, as well as the imaging report. If you want to dive deeper, I give you the complete table of content of the guideline with many articles, about 45 pages. That's it. We'll point at a couple more things. There are some terms that are introduced which are important because we're speaking of those things. The imaging report, people generally agree on that definition. The imaging study, that's come from DICOM, so it's pretty clear. The instance, that's kind of could be an image, could be a DICOM object that is part of an imaging study. That also comes from DICOM. and a key image that is actually coming from Aichi, which is an image in an imaging study that has been flagged as it's a key image. And there may be multiple key images that are being flagged. Why do clinicians do this? Radiologists do this to help the general physician who don't have time to go through all of the images to actually look at the key images first. Rick will further discuss this. The imaging study manifest, that passport, that is a concept that is introduced for the purpose of large-scale sharing. A concept that is very well understood by many, that has been deployed in hundreds of projects around the world, and it was working very well. And some people are recently trying to avoid it and are discovering that it's hard and it's complex to not have a recorded imaging study manifest. We may or may not have time to discuss those details. Medical imaging, we know what it is. Metadata, we know what it is. Modality, pretty clear. Nothing. Okay. That's what happened. Good. So what the guideline does at the technical level, it says you basically need 5 key blocks. You need a means to filter and select and query for reports, and you will need metadata to do that filtering. You will need an imaging report that has some content standardized, an imaging study manifest that has a content also standardized, query retrieve transactions so that you can access the report with its content or access the manifest with its content. And once you have an imaging study manifest, you can dive in further detail, accessing the selected images and bringing them into some kind of a viewer. So the guideline says, hey, functionally, those are the things you need. And if you orchestrate those 5 things, plus the people identification and the security privacy, typically these are the transactions. You query with some metadata parameters, you get a response of matching document entry, the report or studies. You then decide to retrieve specific report, specific imaging manifest. And when you have the manifest that comes back, you can read it because it's standardized. You can read the manifest, you can read the imaging report, and inside the manifest you will find the further detail to allow you to query the specific images. So that layer here is only added to the manifest layer and is specific to imaging. So when you get to lab information, you query for lab report, you get a list of potential entries, and you select the lab report and you get the lab report. In imaging, you do the same thing, but what you get is a manifest. So you need one more, you need a third level of transaction to actually get at the images. So that completes the use case description. Are there questions? Things you would have liked? Is that EHN guideline document useful or not for you? Were you aware of that document before I spoke about it? You had read it. Is it easy to read or hard to read?
It's simple and complete.
Right. Yes, and knowing what's missing is not obvious. It doesn't tell you what's missing. Did you read that document before, or you discovering? You? Okay. Other folks, you were familiar with it? With the guideline? No? Okay. So let's move now into the Aichi multi-country group, multi-country working group. What happened 2 years ago, 3 years ago now, back in end of 2022 at the Aichi conference in parallel with the Aichi Europe Connectathon in Montreux. There was a number of people that said, hey, you know what? We've been doing medical imaging sharing for years in many countries in Europe and outside of Europe. It's wonderful. We have a lot of experience. But the bad news is it's not easy to go and find all of these experiences. What did work? What did not work? What should we summarize? Would it be possible to create a multi-country group so that we can invite people from those countries and hear from them what did they do, what architecture, what standard, how they deployed, what metadata, what worked, what did not work, what are they doing now for the future, what are they improving. And if we could distill all of this as a team and create recommendation so that anybody who is new on the field of imaging or is starting a national deployment doesn't have to reinvent the wheel. Restart where we started 30 years ago. That sounds like a very weird idea, no? But it worked. It worked in actually many countries. We had initially 7 countries. It grew to 10, now 11. And we're going to be soon 12 with Saudi Arabia. I'm slow at inviting you to the meeting. That's my fault. NHS England joined 3 months ago. And I'll give you the list of the country in a minute. So this idea was born. We then got the blessing of Aichi Catalyst and Aichi Europe to create the group, and they would provide the facilities and hosting for the operation. We started by listening to some deployment experience that we know were some of the earliest ones. The rule was we want people that have been deployed for more than 10 years. And we'd like to hear, what are the lessons? If you had to redo it, what would you do the same, what would you do differently? So we had 3 countries here, Quebec, France, and the Venice area. Austria came and spoke a little bit later. That was in the mid-23. And by the end, the third quarter of 23, we said, okay, yeah, it's obvious. There are some good lessons. We kind of know how to make all of that converge and be efficient. So by the end of 2023, the multi-country working group set up some focus group that produced 3 recommendations. Later, they updated them. They even produced a 4th recommendation. And the idea here, and that's what we're going to present now with Rick, give you those recommendations. Those recommendations are documented as slide deck. They're not a course, okay? You need to know a fair amount of things on DICOM, on the standard, on how do packs work, and how do, so if you know nothing about imaging, they're going to be hard to digest. But if you know a good basis in imaging, those recommendations are basically giving you the cookbook on how to set up the interoperability architecture and the way to connect things at the level of your country. And you'll have a variant that you can choose that are matching your deployment and your environments. So that's where we are. The members of MCWG initially were only member state national programs. We now have expanded MCWG. There is a group around it called the Community of Doer, which include clinicians and industry and so forth. We've had a first meeting, and we're going to have many more meetings in 2025 with this Community of Doers. So we now have basically not only proven that it can be done, proven that it's effective, that the countries are very happy with the work that is being done. And we can now expand it and actually be a force that is contributing to the EHDS and its deployment. So MCWG is, its scope is interoperability for imaging. Its scope is mainly national or regional, although we've been asked and we've been working in some area about cross-border because we unavoidably know and understand this, and Rick will discuss this point later. There was a big question when we started back in 2023. Oh, I want everything to be fire. Yeah, everything has to be fire. What does that mean? I don't know, but it has to be fire. Okay. You want your DICOM images to be recoded in JSON fire? I don't know. Can we do that? Everything can be done. Nobody does it, but so you don't know what that means. No, I want to do fire because I want to do fire. Okay, good. So let's make sure we include in the recommendation the places where fire is going to be useful and should be used. And the places where fire would not be that of a good idea, and we explain why, and we had some debate on that topic. An area where fire has no relevancy, and therefore, like every standard, no standard is good for everything. So putting the standard in harmony and linking them and using them to their strengths is typically what has to be done, what Aichi has been doing for 30 years, and that we want to continue doing it here. We had a tremendous pool of expertise, and we had deliverables that were produced in record time. The first three recommendations were produced in 4 months with intense debate, but the debate was intense, but was instantaneously closed after the debate happened. The facts were on the table, and everybody said, yep, we all thought this would have been a good idea, but in the end, it's a bad idea. Or, no, that's a very good idea, and that's what we need to do. So the consensus was quick, and we moved forward rapidly. MCWG meets 1 hour every 2 weeks as a plenary. The plenary of MCWG is setting tasks and goals and topics to be addressed and is approving the proposed resolution brought back by the focus group. So that 1 hour plenary is essentially executive and strategic level. Because we want 100% consensus of the country, and we have 100% consensus on every decision. Today, 11 countries are part of MCWG. If your country has an imaging project and you want to join, you are welcome to do so. Contact me or contact Ariana, who is a lady on the back over there with something on her head. She's our secretary. And the first 3 recommendations are now done. And we've done our recommendation in PowerPoint because we wanted people to be able to present them, which I'm going to do today. But it was an important element that we would formalize them a little bit more if needed. Apparently, there was some idea, and looks like Europe want to create documentation, and we are watching with fear the many layers of document that are being created, not quite sure what they're going to be used for. But we'll see where it goes. But getting the core decision recorded, this is what you have in the PowerPoints. So, where do we stand today? 4 recommendations in green, an extension to the first recommendation, also in green, and some yellow activities that are what we call support activity or complementary activity to the recommendations. We will speak to all of those. First, standards, profile, positioning. That's the first recommendation that typically start with the EHN use case. And from the EHN use case, basically says, hey, these are the architectures you can use, and you will use, therefore, the following transaction profile and standards in that architecture. I want to remind you something that I did not stress in the EHN guideline. When accessing the images, there are two ways of accessing the images. The first way is to use a link inside the imaging report. It's a URL, you click on it, and your browser open the viewer, which is remotely where the images are stored. Why do we do that? Because not all physicians, and patients in particular, have a DICOM image viewer available on their environment. So we need to access images and view them very well with professional quality, remotely, with a server-side viewer. Or you can have the viewer on your side. In that case, you need to get the manifest and gain from the manifest the addresses where the images can be pulled. So we have, in a sense, those two services, a requester side viewer and a server side viewer, and depending on where you are in the workflow, either one can be used. The main decision of this part here is the fact that there are three possible architecture. A country or a standalone region that has a central document registry. Architecture B, a country that has multiple document registries and multiple regions and distributed PACs and VNAs. And last, a country or region that has a central document repository and a central VNA. The last case, C, is typically smaller country or country that have a simple health system where they have put a central PACS because essentially the central PACS serve public hospitals and that's the only thing they have in the country with a few exceptions. We'll eventually come back to that discussion. But among those three architectures, so far we have not found a single country in Europe that would not be happy with either one of them. And if you pick one of those deployment architecture, below you have a choice of transaction and standards. For A and B and C, you can do Firebase document access with MHD. For A or C, you can do it either in XDSI, if you don't like to do it in Firebase MHD. And in B, you do it using XCAI, which is a federated SOAP-based transaction. And in all cases, you have DICOM WADU RS to go and get the images. And in all of those architectures, the imaging study manifest is a DICOM document, not a FHIR document. We debated it. It's being debated and redebated and redebated and redebated and redebated. The spec for the COS document is available or will be available very soon at the European level. That's indeed a topic of discussion that will be covered by Rick in the third recommendation. So you remember the 5 blocks and all of the transactions. Nothing new here. We actually restate the EHN guideline. And from the EHN guideline, we cover and discuss every one of the transactions. The query transaction, the filtering and return report, the response to the query, accessing the imaging report content, accessing the imaging study manifest content representation, and retrieving the images, retrieving them server-side viewer using a URL link, or retrieving them requester-side viewer doing YDO RS to move the images where you are so that you can actually process them fully with their DICOM, all of their DICOM capability. So no big surprise there. This is summarized in this table. In here you see the blocks we discussed in the EHN guideline and the transaction, and corresponding with the A, B, and C. Oh, the B and C are a little cut in my slide. So yeah, I need to repackage the slide. So A is the A architecture, B architecture, and C architecture. And for each one, you have a choice. Sometimes there are two lines. You can do it completely fire or not, or SOAP as you wish. The reason why we did this is because we have people that have already some deployment. For example, France has a fairly large deployment of XDS SOAP-based transaction on a national document registry repository with about, I don't know, 20 or 30 type of CDA. I lost track. More are being added every day. So adding the imaging manifest as a cost object on that server makes sense. We're not going to redo it MHD, although this server has an MHD interface, okay? So it's not, both can actually coexist. So that's where the recommendation A stands, with debate, discussion, notes on every one of those choices. I'm not going to go through those, I don't have time. And we have something which is fairly complete, not 100% complete, but fairly complete. And that brings us to the second recommendation that has to do with metadata linkage, metadata and linkage. So, what metadata should we select? We worked a lot on this. The goal of the metadata is to be few attributes. And for each attribute, a few value. Why? Because if you expect a clinician to select many things with pull-down menu of 20, 30, 40, 50 value of metadata coded information, you're on the wrong track. The physician will never use that metadata, and he will bitch against you, saying that you made things non-selectable. And you're going to show him that it's perfectly selectable. Yeah, but look, how many anatomical parts do you have? Oh, 150? And the clinician is going to tell you, I'll never select among 150 values. Got other things to do. Not going to spend my evening on your interface. I don't want more than 10 value. If it's more than 10, you're out. So metadata is a very demanding exercise. So what we have here are the 6 key metadata element: anatomical region, the study modality, the UID of the study, the accession number, the placer order number, and the imaging procedure code. You note that only the top 5 are usable to filter, and the imaging procedure code is used to select. So when you get the response, you can see the procedure code being displayed and pick the one you like and ignore the one you don't like. You cannot select and query by procedure code. Why? An average imaging department has 1,000 procedure code. Some have 2,000, some have 3,000. Go back to the previous discussion. Who is going to select a procedure code among 3,000? Even if it was done, it would be a mistake, because it means the same procedure can probably be recorded under 2 or 3 different procedure code. because procedure codes overlap. In some cases, both can be used. So you see the danger of having fine-grained coded information for metadata filtering query purpose. And that's what the MCWG did here. This is the example of the anatomical part. 10 value. That's it. You see that those values are made of large anatomical element, like the lower trunk or the upper trunk. Head and neck has been put together. A couple vascular system that are pervasive throughout the body. The cardiovascular one, the heart, the breast, the spine. And that's it. No more, no less. Believe me, you can filter in a very efficient way, reduce by 90% the unnecessary procedure if you filter with only those 10 values. Linkage. Yes, we have an imaging report. Okay, we have an imaging study. Oh, yeah, we track the clinical order number. Oh, and the imaging procedure request accession number. So there are things we don't have object, but we have the identifier. And what is the relationship between the imaging study and the imaging report? Everybody will tell you one report on one study. Every study has a report. Wrong, wrong, wrong. You may have multiple reports on a single study. You may have multiple studies served by a single report. You may have some study without a report, either by error or by design. Okay, so the relationship are all 1 to n. Better make it generic from the start so that you have no bad surprise as you deploy and do your search and move around. If you're not convinced by the cardinality, look in the yellow boxes. You will see all of the examples that we gave to show that indeed those cardinalities have to be generic. I'm going to be skipping this. There is other metadata that is generic metadata that you have to use to query with author information, with practice settings and so forth. I will skip those. We don't have time. I'm already over time. One last point of interest. You have to manage time zone. If you believe your country is in a single time zone, you're wrong. Rare are the countries in Europe where all of their systems are in a time zone. They always have a little island somewhere remotely that you forgot that is in a different time zone. And as we are in Europe, we have different time zones. So you need to know how to manage time zone, and this is a problem that MCWG has addressed. I want to stop here, pass the ball to Rick for the imaging study manifest and the significant images. Sir, over there, can you switch the slide deck? You have to wake him up. Thank you.